Hey folks, so a couple of things to start out with. My name's David, and if you're here, it means you've prioritized us over Katie Couric, Brooke Shields, and
Meghan Markle?
and Meghan Markle. Meghan Markle. So we're going to make this more entertaining. And so I don't want us to really do a panel. I want to set the stage a little differently. I want to pretend that you and I, the four of us, just met for coffee. And we're going to talk about this subject together. And you folks are at a different coffee table, but you're going to start eavesdropping and listening in, and then eventually it's going to become one big conversation, okay? So that's the stage. So my name's David. I'm the chairman of Oracle Health. And before I introduce this esteemed panel, I'll talk to you guys like we're in the coffee shop. There's a few patients that I've cared for, and I'm a child psychiatrist, that have just stuck with me. And for a lot of reasons. Well, I actually feel like for whatever long I've been in this 30 plus years, I'm just trying to make it better for these two patients and their families. So let me describe them. And I think it really sets the stage for the role of technology in mental health, okay? So my first patient, I know exactly how long this was ago because our daughter was just born, and she's now 31. So it's 30-ish years ago.
Wow.
And I'm in my last year of training in child psychiatry at UCLA. I was really proud because it was the first time I had an office. Now, my office was so small that when I brought the dad in for the family feedback, I had to close the folding chair to open the door, and then you'd open the door, but I had an office. And this patient was a 12-year-old boy who had his first psychotic break, and he had come from Las Vegas. I was at UCLA, and this was me giving feedback to his dad. And his dad was a car salesman, Cadillacs, used from Vegas. So think of the stereotype, he nailed it. It was like central casting. And I thought back then, 30 years ago, that I was actually really smart. I was at UCLA, I knew a bunch of stuff. So I'm telling this dad in this little office, we're like sitting this close, about the nucleus accumbens and ventricles and anticholinergic. I mean, I'm super good at this, right? And the dad looks at me and he says, "Do I have to build a room out back?" And I just started crying because what was clear was the trajectory in his life. He's a single dad, and he knew way more than I did about being a parent and what that meant. And I thought about what as a new parent, like, what does this mean when you get this devastating, life-changing trajectory of somebody with serious mental illness, and in this case, a kid, and getting to the technology part, what can we do that we could actually explain things to people in a way they understand? I was really bad at it. And it was at that point I was like, I'm going to talk with people in a way they understand. That's one piece. And I just think that should be part of our theme. And the second case is a couple years later. I'm now a faculty member. And this little girl in third grade at the local school where my kids actually went to school writes in her haiku poem that she wants to tie yarn around her neck and commit suicide. And this is pre-cell phone, guys, pre-technology. The teacher reads the haiku poem and tells the principal at home that night, tells the principal the next morning, right? You didn't even call people with cell phones then. The principal then calls the mother at home, and the mother calls the father, and the father eventually tells me, I've never been interrupted in work where my wife says, no, you must get him now, and that was one of those times. And then this is LA, and because they knew people, they were able to get in to see me in 3 weeks. And I was like, oh my God, if my kid was suicidal, it doesn't matter who you know, you got to be seen today, right? So that was when I was like, okay, not only am I going to explain things in a way people understand, I'm going to fix, I didn't know this word, but I know it now. I'm going to fix access. I mean, that's what we use as this term. Yeah. Access to me is my kid is suicidal and I'm calling an 800 number and my insurance doesn't cover it, or I got to pull strings, and God forbid I'm from the other side of the tracks where I don't know anyone. I will never get in. So how can technology help there, right? Now, I think what we're supposed to talk about too is the negative part of technology, right? I'm stuck on my phone. I'm not socializing. We all go to dinner and we're like this instead of actually being together. There's probably people right now on their phone not listening to us. Come on, right? That part is kind of be part of our discussion. So, does anyone need a latte, or are we good to jump into it? We're good?
Good to go.
Okay. So why don't we go down the line and introduce yourselves? We've had some pre-calls, but I like to keep it fresh. So introduce yourselves, and then let's just jump in.
Sounds good.
Okay.
Hi, everybody. I'm Michelle Quinn, and I'm a psychologist and a child psychologist, and I'm director of research at the Menninger Clinic and an associate professor at Baylor College of Medicine. I'm excited for this conversation.
And can we talk managers for a second, because
Sure.
it's got both Kansas roots and Texas roots, right?
It does,
Yes.
yes.
So tell us the history, because it's one of those storied places.
Yes. So the Menninger Clinic is really known for humane treatment of mental illness. We are historically known as an inpatient psychiatric hospital, and really revolutionary in something called the therapeutic milieu. And so kind of actively intervening and doing psychotherapy while someone is inpatient. So it's not a passive intervention. And it's really just remarkable. We still hold on to that kind of psychotherapy within an inpatient context to this day. So we moved to Houston, I believe, in 2008, and have been there ever since. From
Topeka, Kansas, right? And it started with Dr. Menninger in some years and years ago, right?
Yes, the Menninger family started it, and Dr. Walt Menninger is still very involved. He still lives in Topeka, but he is 92, comes to Houston. I have a meeting with him in a couple weeks, and he very much, actually, it aligns really nicely, I think, with our talk. He loves, despite being 92, he loves data, he loves outcomes, and he is 110% still committed to improving outcomes, particularly for people in intensive mental health settings.
Beautiful.
Yeah. So.
Hi, I'm Tracy Walden. I'm a clinical health psychologist. I'm the chief clinical officer for Quinn Veterans Network. We're a network of mental health clinics across the U.S. We have clinics in 16 states, supporting 25 states, though, and that's because of telehealth. So we don't do solely telehealth, but we've been able to utilize telehealth in order to expand our reach across the U.S., and we're looking into some opportunities overseas as well. I'm also a veteran of the United States Air Force. I served for 24 years and served as a psychologist during that time in the Air Force as well.
Hey, Tracy, before we go to Danny, first of all, thank you for your service. Can you give us a little background, because your organization got started by a visionary also, and it's pretty amazing what one individual and family can kind of do.
Yeah, it's amazing. So Mr. Steve Cohen, so Steve and Alexandra Cohen, for those of you who may be from the East Coast Mets fans, they own the Mets, and he's a philanthropist. His son joined the Marines, and his son came back, and his son didn't need to join the Marines. He chose to join the Marines. And he came back and said, Dad, this is where you need to put your money. You know, my buddies are coming back, and they don't have access to good mental health care. And so it started with one clinic at NYU, and then that was successful, and Steve said, you know, I want to do more. When I joined this network in 2017, we had 8 clinics, and now we have 25 in that short period of time. And so he's been extremely generous in order for us to provide services where oftentimes there are no services, because we serve not only the veteran, but the veteran's family members. As a veteran myself, my family doesn't have access to care in the VA, and that's no fault of the VA, it's the way the system is set up. And so we're able to reach and provide those resources to families, and in a much shorter time period, especially due to the advances that we're going to be talking about now with technology.
Amazing. Before we go to Danny, I just want to say to you folks and all the women in our lives, happy International Women's Day. And when we talk about healthcare and mental health care, the impact that women have is, I mean, in the family, that alpha mom who ends up taking care of everything, I always say it's not because she necessarily wants to, it's because no one else will step up and do it. A huge amount of gratitude. Danny.
Yeah, thank you. And so I'm Danny Gladen. I'm the Director of Behavioral Health and Social Care for Oracle. Happy to be the social worker on the stage. March is Social Work Month, and I'm really proud to work with just a whole group of social workers in the delivery of mental health services and all the great work social workers do. So I was sort of listening, David, to you describe kind of some of your early interactions with patients. I was thinking, in 2009, I was working for a distance behavioral health organization. Our services were phone, video, text, and chat. Now 2009, and Avatar. We had created an avatar in which young people could interact with a mental health professional. At the time, it was fairly innovative. There wasn't a ton of distance or now telehealth behavioral health services. I had a client. I was from the Ozarks, sitting in an office in St. Louis, Missouri, and there was my very first telehealth client was a beneficiary and a member of the Tlingit tribe, Alaska Native. He was living on an island outside of Hoona, Alaska. Hoona's in southeast Alaska. So in order to see me via telehealth, sitting in St. Louis, he took a boat from the island to Hoona, took a float plane from Hoona to Juneau, and then walked into this clinic with about a $12,000 Tannenberg piece of hardware, so that he could sit and talk to me sitting in a cubicle on a laptop in St. Louis. It was pixelated, and I just think about, from an access perspective, how far we've come. Today he doesn't have to leave his island outside of Hoona and hop on a boat and then a plane just to get telehealth access. He has the ability to use a phone or an iPad and access mental health services. Dr. Afsar earlier talked about democratizing access, and I think that the beauty of, if there's a dichotomy here, the beauty of technology is that folks can get now real-time, barrier-free access to mental health services. They can use hardware to be able to kind of tell a more holistic story about their presentation. And yes, I'm sure as we continue the conversation, we'll also talk about the harms of technology. But really, democratizing access has been so very important.
So we've already gotten started, because as we've gone down the road here, everybody has kind of put in, hey, data's good, telehealth's helping, it's helping with access. So that's the good of technology. Let's stick there for a second, but get ready, because we're going to go to the negative of technology. So today, what in your organizations is happening from a technological standpoint that you think is improving access, improving quality, democratizing care, making care more affordable, more culturally sensitive, helping with inequities that we know that are in care? What are you doing to harness technology, forget the bad stuff for a second, that's actually helping individuals, patients, families, communities?
I'll start.
Go for it.
Yeah. So it's not really revolutionary in any way, but we use iPads and research assistants and collect outcomes data across our whole hospital, and with inpatients and outpatients. Outpatients is pretty standard. People are able to complete, outcomes measures, self-report. Inpatient, it gets more complicated, and we have to guide people, help people. Sometimes people resist, don't want to do it, and that's fine. They don't do it. But that, to me, is the foundation, right? So if you collect outcomes data, that gives people a voice in their treatment, particularly on inpatient. So our inpatient units are locked units. You have reduced someone's autonomy. When you measure how they're doing from their perspective, it gives them some control back. And I think that is one of the most powerful things that we can do, is give people control back through data, and measuring these things and measuring the change over time, whether it's positive or negative. And technology allows us to do that. So many of our patients want to use the iPad, and then we visualize the data in graphs that are provided to the treatment team through our electronic health record. And so that gives data-driven feedback that the treatment teams can actually provide to the patients at the patient level. We also use it for research to understand aggregate results, what's working for who. And what's not. But I think, I'm biased, I'm director of research, so I love data, I'm the PI over our outcomes, but I think that's tremendous. And we can advocate for, better inpatient environments, better inpatient care, better inpatient outcomes.
Can you give I think it's a great example. Well, first of all, the simplicity of it is sometimes to make things simple is really hard, and so this is great. Can you give an example of something you've done based on the data to change how care is delivered?
Yes, so, something we're working on right now, all of our results are lining up really around the role of sleep. One thing that we are constantly thinking about is suicide risk with inpatient, and particularly suicide risk post-discharge. For those of you who may not know, post-discharge from inpatient is the highest risk period for suicide over and above any other time in someone's life. And also relapse. So post-treatment in our highest level of care. And to us, that is incredibly concerning. So we have been really thinking about the role of sleep, as well as other measures, and look at longitudinally outcomes while someone's inpatient. What is predicting suicide risk? And we have a paper that we published. We showed it is sleep over and above everything else that you can put in the model.
And you measure using Oura rings and things like that, or how are you measuring
Not
sleep?
yet. We are now, because it is so important. And we've now designed our own API and with wearables to replace things that we do in inpatient that actually disrupt sleep. So Q15 checks.
Correct.
And these checks, so there's checks done on inpatient to ensure someone's safety, in-person checks. And these are often pretty disruptive. We have data now from actigraphy that we've lined up with the checks, and about 75% of those checks, so someone going in their room, usually a stranger that they do not know, opens the door, sometimes shines a flashlight in their face to make sure that they're breathing and that they're asleep. Or if they're not asleep, they'll ask them to raise their hand. And for us at our hospital, it's every 15 minutes that happens. That equals about 36 times a night someone comes in their room. So we've designed our own kind of in-house homegrown system to replace that. And that is one, and it's just one thing that we always say, technology is, gonna take over and ruin people's privacy, things like that. But in that situation, it improves people's privacy. People can sleep and have intact sleep.
Great example.
So it's that, and that's one of our favorite examples, right? Just kind of generic outcomes data into a new intervention that leverages technology that improves somebody's outcomes, hopefully, in the end. We're still working on it, but.
So cool.
Yeah.
Tracy?
Yeah, I think it's really interesting what Michelle just discussed in terms of outcomes, because we do measurement-based care for all of our clients. So we measure their symptoms at every session, and we do that via iPad if they come into the clinic, or we push it out electronically for those who are being seen via telehealth. And one thing that we found is that we wanted to take a look at how effective is telehealth? Because many people say it's not effective. You know, prior to the pandemic, people were very skeptical. And we actually use this data, and we have a research institute that's part of Cohen Veterans Network. And within the institute, they reviewed the data recently, and we found clinically significant change in PHQ-9 scores for depressed individuals, and for those with PTSD, clinically significant change in their PCL5. So these are the measures that are the standard measures given for those populations. And not only did we find clinically significant change, but we also found that those individuals were in remission. And this was with a standard course of treatment, about 10 to 12 sessions. But of course, it's evidence-based therapy, so it's not just talking to someone, it's utilizing strategies that have been found to be effective with that diagnosis in this population. And so we were pretty proud to see how effective it actually is. We thought it was effective, but it's nice to see the data. And so that's one of the things that I love about technology. It allows us to get those additional data insights. We rolled out telehealth in 2018, so before the pandemic. And we did it to improve access, and not just access due to long waits, but to decrease no-shows and to improve that accessibility for clients who are already in care. I remember a few years ago I had a client, and we would advertise in our clinic on we had rolling slides that would tell about the different things that we offered, and we had a slide that talked about telehealth, and it said, ask your clinician if you'd like to know more about it. And my client came in that day and said, hey, would I be a candidate for telehealth? Because I fall asleep on the drive home from here. And I was like, yes, you would be an excellent candidate. And, you know, this was an individual who he was driving an hour each way to come and see me, and he was taking sick leave during that time. So taking time away from work in order to, it was great that he was taking the time to take care of himself, but 3 hours of sick leave each week. And we were able to reduce that to just 1 hour. And in some cases, he didn't have to take any because we were doing it via telehealth, he was able to do some of those later sessions. And what I think what also is really great is we often think about the benefit to the client. It also gives some flexibility to the clinicians, because sometimes some clinicians may have things in their life that they need to take care of. And so I was able to look at my clinician's schedule, and many wanted to be at home to cook dinner or pick their kid up, but then they would get back online in their home office and do a 7 o'clock or 8 o'clock telehealth appointment. And that worked well for the clients also. And so I think that telehealth really gives us great flexibility, not just for the client or patient, but also for the clinician.
Hey, Tracy, if I'm a veteran, I'm feeling depressed, I got a little PTSD, there's a lot of stigma and a lot of shame with the words I just said, and really words that feel more comfortable to me are like resilient and tough it out and those kinds of words. How do I find Cohen Veteran Network? And if I do, how do you talk to me in a way that fits with the words I use? And then if we get through that, how fast can you see me?
Okay. Those are great questions, and so there are several ways that you can find Cohen Veterans Network. You can Google us, and we have a website that then links you to each of our separate clinics as well as our overall central office. The VA is well aware of us, and so a referral can come directly from the VA. A referral can come directly from the Department of Defense. And then we're very well integrated in the communities in which we're located with veteran service organizations. So we've really done a lot to make us as well known as possible. And being here increases that as well. So hopefully that'll help some additional veterans. In our clinics, approximately 50% of our staff are military connected. So they're veterans, some of our clinicians are spouses of military, and so they have that military, I hate to say cultural competency, because competency implies that you've achieved a level and you know everything, but they have that cultural humility related to working with this population, and that really helps. It goes a long way. So I think that that's really important. Because of the need for mental health has increased significantly, especially during the pandemic. Prior to the pandemic, we were getting people in within 2 weeks, oftentimes a week. Now, it can take almost a month. However, we screen all of our clients to triage them to see how quickly they need to get in. And the example you gave of the little girl who was in crisis, we would have seen her same day.
Yeah.
And that's also the beauty of telehealth, because it allows you to oftentimes squeeze additional appointments in if someone no-shows, and it helps to prevent no-shows too, because oftentimes some people like to come in. They like to come in and see their clinician face-to-face, which is great, but sometimes life gets in the way. And so if someone calls to say, hey, I'm gonna be late, then we say, would you like to convert that to a telehealth appointment so that they don't have to miss that appointment? And then one other thing that I thought about when you asked me about working with veterans and that stigma, it makes me think about a Marine veteran who I had as a client a few years ago. And this was, real tough guy, very stoic, was coming in for individual therapy, never really showed much emotion, but he had a connection with me, and so he was coming in, he was working through things. When we started telehealth, which we had to at the time because of the pandemic, I got so much more emotion out of him. He was willing, and it wasn't that I got it out of him, I shouldn't say it that way. He was willing to show more emotion and be more vulnerable because he was in a setting in which he could do so. He didn't have to get himself together after the appointment to go out into the waiting room. And so that's one of the things that I really love about telehealth, is that it allows an individual to get the care in the environment in which they feel safe and comfortable.
It's kind of paradoxical that in some ways it's more intimate, and yet you're physically separate, but there's some safety in it. That's a great example.
Yes.
Okay, Danny, take us home on the wonders of technology, and then we're going to flip it.
We're going to flip it, okay. Well, so for Oracle, we build tools. We build tools to ensure that the work that providers are doing with consumers of care have what they need to sort of ensure that the clinical experience checks the box. So the 15-minute check that Michelle was mentioning is something that happens in our tools, and the PHQ-9 and the screening that happens in our tools. I don't know if you know this. Well, I bet you probably do, but there's a lag in kind of the behavioral health space, right? Healthcare in general has been fairly advanced from a technology standpoint. Behavioral health we sort of come along late, and that's for a variety of reasons. But if you're trying to track data over time, and you've only had tracking the data on paper, makes it very hard to understand someone's progress or regression over time. Now in our systems, every 90 days, we have over 1 million suicide screenings, right? We've embedded in the workflow for nurses, for oncologists, for the ED attending, we've embedded in the workflow suicide screening tools and then alerts, so that if someone is at risk, it's not just one person who's aware, but the entire treatment team can have visibility face up to this type of information. And so we sort of want to help folks use digital tools to be able to track patient information, to be able to get folks in quicker. But I think beyond that, the beauty of technology in general is there's an opportunity to tell a fuller story, through wearables, through some of the cognitive behavioral interventions, the digital therapeutics. It just really provides a variety of different types of modalities for consumers of care to be able to deliver inputs about their experience. If I have to get in the car, drive to a clinic to see Michelle in person, I'm putting on a mask, and all you really know about this individual is probably what happened in the hour or two before they got to you. Like it's the stress of the moment. Using wearables, using sort of digital inputs throughout the week, in between sessions, I'm able to sort of have a more holistic picture of what your week looked like. And because you're doing the session in your own home, you don't have to put on a mask. It is more intimate, and I'm able to, as the provider, just have a more holistic picture of what I'm working with.
Okay.
Can I add one more thing?
You could add 10 more things.
It gives you more accurate information. As I was thinking about what you were saying, Danny, about the technology, and you, Michelle, when you were talking about sleep. Sleep is one of the #1 concerns within mental health. People may come in with issues such as depression, anxiety, PTSD, but there's usually an underlying sleep problem. And as a health psychologist, I love to treat sleep. But clients historically underrepresent the amount of sleep that they actually get. And by using something like a wearable, a watch, or Oura Ring, you get that accurate data that then you can immediately share with them, or they can see it immediately themselves.
Okay.
Can I
This
just?
is great.
I
You
got
know what I
one more
thought was
thing.
so good about the last panel? The moderator stopped talking because the panel took over.
Wanna
So you guys got full permission to go for it.
Okay, I'm just going to carry the ball and I'll
Hey,
pass
guys,
it to you.
ask
okay,
me a
right?
question
Yeah,
once in a while.
okay. I just want to add, I completely agree with Tracy and Danny. And I think the beauty of the data, when we talk about outcomes data, self-reported data, those data are collected, every week. So you have huge gaps in the information that you are getting about somebody's experience. Our emotions can change within seconds. There's can be a traumatic event happen, or just an argument with someone. So our lives and our emotions, behaviors are very dynamic, and our outcome measures and the data that we have now, this is why I love wearables. And I've always loved wearables psychophysiology, because it fills a tremendous gap in our ability to measure the dynamic fluctuations and the way our emotions and behaviors change. That is so important, I think, for understanding the ultimate outcome, and just that the kind of higher temporal resolution of the data is something we don't have now in practice. There's such a research to practice gap there that I think technology will certainly fill, and also has the potential. And one reason I love the wearables, because it really demonstrates that it's not all in your head.
Yes.
Too. When you do a self-report, that is your perception, right, of how you feel. And with the wearables, too, it gives an objective marker for the first time in vivo, in the situation, to show, hey, I'm really experiencing this. This is real. This is how I'm inside.
Yeah, now think about this just real quick. Like in our
Now we're cooking. Now
Yes.
we are
Yeah.
I mean, well, in our discipline, historically, we don't get access to labs. We don't get access to some good radiology scan. We find out something about someone by asking a bunch of really nosy and intrusive questions, by observation, or someone has sort of engaged, has had a crisis, and they, either through the courts or corrections or probation. And it is point in time. Like, how many times do you start a session where, how have you been since I saw you? Fine. right? I mean,
Yes.
and that's sort of the starting point. So the ability to have real-time inputs, the 7 or the 14 days in between the times of seeing each other, is just enriched the clinical experience so much.
Okay, I'm going to give an example that fits with everything you're saying, and then I'm going to give a completely one that gets us onto the next subject, which this is terrible. Technology is ruining everything, okay?
Okay.
Yep.
So when I'm in training, I'm seeing a therapy patient weekly. I think it was a woman I was seeing Tuesdays at 11. And my supervisor says to me one day, "Do you ever think about your patient in between sessions?" I'm like, "Of course I do." "Have you ever said that to your patient?" I'm like, "No, are you allowed to? Like, are you supposed to?" He's like, "Well, if you do, you should tell your patient." So then you tell your patient, "Hey, I've been thinking about you." It's unbelievably therapeutic. So we'll think about technology as a way to reach out to patients, not only the wearable stuff coming in, but me saying, "Hey, Big Data's helping me, but they just came out with this thing showing something that has to do with your condition. I've been thinking about you. Here's information." So I think it's a two-way street. It's beautiful. Okay, we're flipping gears. So this is actually called an ultra-human ring. I do have an Aura. I got this. I got a Google pad, a Google thing in my bedroom that watches me by sonar how I sleep. I got another thing under my mattress, and my wife is like, "No more tech in the bedroom."
No.
Like, and she's like, she's creeped out by it. I get it. So what are we talking about? We're bringing stuff into the bedroom. We're bringing stuff into monitoring. We're getting this constant influx of information. Hey, that could be problematic. That could be driving. I'm actually concerned about, now I'm just channeling. This isn't me, but I'm throwing it out there. I'm concerned about privacy. I'm concerned about the security of the data. I'm concerned that, hey, if I tell you stuff, this is going to get to my employer. You know, when we talk about stigma, the median onset for somebody with obsessive compulsive disorder to tell somebody they love that they have this disorder is 9 years. Median. People hide this stuff. So we could say stigma's better. We got movie stars talking about mental health. That's all cool stuff. Still, internally, this stuff is really hard to deal with. Now, well, why are you wearing that ring? Oh, I'm measuring my sleep because I have depression. You know, this stuff can be bad, right? So what are your concerns around tech not helping us? Tech distracting us from human connection? Tech meaning if you stare at your phone all night, you don't sleep well, right? So here we're talking about sleep, but before you do it, please answer this patient-reported outcome on your phone and do a little TikTok because it's addicting and the serotonin goes off and hit your Instagram. Like, this stuff's terrible. So how do we deal with that? What do you guys think about that?
I'll start us here, and you know, I still see a few clients from time to time. I particularly enjoy working with adolescents, and the sort of the narrative from adolescents and the stories they sort of come up with in their mind about the world around them is really quite distorted. You know, based on the stories they get from social media, and I'm not talking about sort of fake news, which is its own lane, but sort of the attitude that, you know, folks around me are just having a much better experience than I am, and what we all know is there's likely all of it is inflated a little bit or a lot of it, right? And so we know this. We know that the data on sort of overuse of social media and the link to depression and anxiety in young people is real. What we are seeing, though, is that transition. You know, it's not, so if I'm down, if I'm feeling bad about myself, I'm now starting to engage in, you know, in ways to numb that pain, and that's, you know, through self-harm, through self-injury, it's you know, through alcohol use or other substances, or it's it's sort of engaging in relationships that are unhealthy. So I'm really from the adolescents that I get to work with, I'm really concerned about that. On the other side, the part that concerns me about tech is I mean, we've just sat here and talked about all of the benefits that technology can bring, the access, the data, biophysiology data, but the problem is there are people left behind. There are people left behind in the most remote parts of Alaska. There are folks that are left behind within a mile radius around here, and so we have to ensure that the tools that are created impact and benefit all of the people. And so I think tech access, tech literacy, all are concerning to me as so much of our particular discipline moves into the tech space.
I'll kind of jump off from there. I think when, I'm not in the tech space, but I love technology. But I think technology does such a good job with some of these data privacy issues. And they do a lot in terms of the technicalities of how things are going to work, what the interface looks like. Are there protections in place, right? That safety is built in. I think one thing that is forgotten though, and I don't know if we even knew that was going to be a consequence, is no one was testing the psychological safety of these technologies, especially when it comes to social media, right? I remember getting Facebook in college and everyone's like, this is amazing. No one was like, oh, this could be harmful someday. It was like, oh, I can connect with like everybody in high school and I'm getting messages from everybody. Like, this is awesome. I see everybody's pictures, which now I'm like, why did I put those online? But, right? So it was so positive. No one was thinking of mental health consequences. And I think that is just, as we, are kind of zooming forward with technology, there's all these, kind of ethical safety guidelines. American Psychological Association has done a really good job at starting to think about the psychological safety. What are the psychological kind of safety parameters that we need to test as we develop new technologies? But also then how do we put the guardrails up on the things that are here now?
Hey, Tracy, I totally agree. Great, because I think I'm forcing you guys here, but I think it's important to have the discussion. Tracy, I remember going to like Fisher houses, and you'd see these veterans, wounded warriors, and you could just see the physical wounds, and then they'd take you around these Fisher houses, which are just, in some ways Ronald McDonald for injured servicemen and women. And they'd make these rooms that were super dark with a big screen TV, and you would just see them playing for hours Call of Duty and just shooting people up. And I'm like, whoa, what's going on here? Like, what are we doing? So how do you think about it, particularly with the veteran community around that re-traumatizing exposure and all that?
Yeah, that's very difficult because it does re-traumatize them, and because the video games nowadays are so vibrant and realistic, and so it's very similar to what you would experience in the deployed setting, and or if you were doing virtual reality psychotherapy or exposure therapy, and so that's. But they're not doing therapy, they're just exposing themselves. And so it sets individuals up for increases in their symptoms and or relapses if they had gotten care in the past. It also results in them being really isolated.
Totally.
They have these relationships with people, but they're relationships with people online, and oftentimes somewhere way across the country or perhaps even in another country. And I've had clients who spent whole weekends. They'd get off of work on Friday and then they spent the entire weekend gaming, and their gaming conventions as well. That I think is a little bit better because people go to these conventions and have some interactions. And so that's really the key, trying to identify other ways and other things they can do. They have made some changes to the Fisher houses, not much. We're actually looking at how we can support, our clinics are looking at how we can support the Fisher House in order to help them to look at their environment. How can they improve the environment? What other things can they connect the veterans to so they're not just stuck on that technology?
Yeah, and the Fisher houses are amazing.
They are.
I'm just talking about this one thing that I saw there. I mean, it's amazing. You know, you feel like you're at home, and it's amazing. But I was like, whoa, this is serious. Now, we can thank all that gaming to help us with AI because it developed the chips that now we all build our models on. But I just don't know that it's always the right thing.
Right.
Tell me other things that concern you about technology and mental health.
I actually have another thing, and I'm going to shift it a little bit. I get concerned from the clinician perspective because technology has really helped us. Instead of, giving a paper, I remember when we gave out the paper and pencil measures to our clients when they came in to the door. You had to wait for them to finish it. But the good thing about that is when they did, then I immediately had it. I reviewed the scores. Now, measures are sent to us, automatically, and then they go into our system. And so you really have to train the clinicians to utilize that data and not just have the client submit their data without it being utilized. Someone could submit data that could indicate that their risk status has changed, and if it's not being looked at, that's a huge concern. We're also looking at ways to help clinicians with documentation. However, a concern that I have with that too is that, if you're using AI to do your documentation, there could potentially be errors. And so we have to train our clinicians to properly utilize these wonderful technologies so that they can use them effectively.
Yeah, we're working really hard on that right now. I think we got good stuff coming out.
Well, yeah, and actually, so because we don't have labs and a radiology scan to sort of show a payer, here's the evidence for the diagnosis, our discipline is very narrative rich. And just to be able to sort of either get a prior authorization for service or to be able to continue service. And so we have a clinician burnout issue because of the administrative burden, the documentation burden, so that's and the tech just facilitates that. But I do think is exciting and. Ambient and generative AI and ambient for documentation, our slice of the pie has been carved out. And I'm so excited, and so Microsoft has gone, there's some other startups out there that have gone, Oracle's working on its tool that will really shift the burden away from documentation. I think it's going to be a game changer.
Yes.
Okay, I want to invite my friends in. Questions, comments? Yes, please. And they told me they will yell at me if you don't use the microphone. And I don't like to get yelled at. Will you go over to the microphone? That's okay, but I have my own psychological issues of not getting yelled at.
Thanks, Dr. Feinberg. So, very interesting topic. I'm actually curious, you guys talked a lot about people that already recognize they have a mental health issue or you've diagnosed them. How can technology be more useful in helping people find mental health care or to even determine if they have a mental health challenge?
Hey, we did PQH9 at Google. It was the first screener that we put up. And we'd get 1 million people come to it a day with a 90% completion ratio. And I get to Google, it was done before I got there, and Google is going to take it down because 1 million people on a Google site is very low penetrance. I'm like, whoa, guys, I've had patients that commit suicide. If we can get one person, this is great. So then we did PQH9, then we did generalized anxiety, then we did post-traumatic stress disorder, then we did postpartum depression, and then we did athlete's foot. Apparently a lot of people Google athlete's foot issues. So they were good, safe things to do. So that's just an example of, and it was amazing. look at what people put in the search bar. Is my boyfriend pimping me? Like, that's what people ask, right? And then you can start helping them understand, are they being traumatized or trafficked, et cetera. And the same with depression. People don't type in, for the last 5 out of 10 days, my mood has been down, I'm hopeless, helpless, guilty, having some anhedonia. They don't type it in like DSM-5, right? So to be able to then get them to a anonymous screener and see an amazing completion rate, 90%, was pretty amazing. People, you said it before, where you said people, Tracy, in some ways were more open to you when they were virtual. There's good evidence people actually respond to computers more honestly about their depression and suicidality than they do to humans. So I think one way is to use tech for people to I don't want to say self-diagnosis, but start the journey of, am I suffering from something? It's a great question.
And it can be set up to then provide resources
Correct.
to them immediately.
Yeah, the next step is crucial, right? I mean, because we don't want to leave you up. I mean, that's the other thing that we found is if you touch a lot of people, but then have nowhere to send them, you shouldn't even be asking the question.
Right.
Yeah, I think we're also seeing, we're also seeing sort of payers and other sort of adjacent to healthcare using LLM to sort of comb a phone call and start to tease out keywords that begin to tell a story. Also, use of voice biomarkers. You know, does the tone and inflection of your voice or the cadence of your voice sort of point to a potential distress? It should not be diagnostic, but it should say, hey, more evaluation is needed. And so I think those are great ways that tools can be at least prompt further screening.
And how many depression screenings did you say we do a day or something like that?
Oh yeah, so we're doing a million suicide screenings a month.
A month.
We're doing
And that's not for patients that have yet necessarily been diagnosed.
These are non-behavioral health patients. So this is the podiatrist, this is the ED attending, and yeah.
I was just going to say, you know, there's definitely some negatives of social media. I think one of the really positives of social media when it comes to mental health is connecting people to people with lived experience of certain diagnoses, because I think, you know, we can give a PHQ-9 and all these measures all the time and do a SCID, which is a structured clinical interview to diagnose people. But if people don't have insight and kind of accept that, understand what it may be for them, they're not going to seek out help. And I think, you know, things like TikTok and you know, different communities online have actually been invaluable. People can anonymously kind of understand somebody's experience, see if that may relate to them. They can give really good resources. There can be very good resources in a community out there that really can reduce stigma, ultimately, I think, too. So definitely negatives of social media, but I think that is one tremendous positive and can help just build a community.
Yes, please.
And what about AI stepping into the shrink's role? You said people communicate with computers better and they open up better. AI doing the job that you guys do. Do you see that happening?
Yes, so the evidence-based treatments like cognitive behavioral therapy, dialectic behavioral therapy, really fit a model where you could really do a lot of training to step into the shrink's role. I think that it'll be more of an augmenter, that you're my patient, but maybe during the hours between when I see you now and 2 weeks or in a week, there's an AI chatbot that I'm helping supervise that is helping you whenever you need it. Like, to me, that feels where it could scale and you get better care. But hey, we should come back in a few years and maybe we won't be here and it'll be all AI. I mean, I don't know. I mean, we'll see. I think it's great. Yes, please.
Hi, I spend my winters in San Diego and my summers in Maine. And in both places, the same problem exists. There is not enough psychiatrists, particularly child psychiatrists, for access. Not telemedicine, not payment out of pocket. not anything. What is the technology going to do about that? Because the primary care doctors are being psychiatrists, and they are not trained for complex psychopharmacology.
Yeah, I would say a couple of things. One, the telehealth access issue is not just about access for the patients, but it's also access to workforce. And so, there's some state politics things that have to happen here, where a licensed provider in Maine can also see patients in California and vice versa. The need for reciprocity across state lines, because there are parts of the country where there are less access issues because they're particularly academic rich cities, and so that's just one way. It's just that tech is not just about access for consumers, but it can be access for providers.
But there's no access in the state of California, in this case, or San Diego, and in Maine, right? I mean,
You're probably seeing it, if you still live in Los Angeles, it's probably the same.
oh, totally.
Yeah.
Yeah.
So it's just because you have a bunch of academic centers does not change the situation. There are 2 major medical schools,
In San Diego.
but there's a major, and then there is Irvine, and still not even close.
I think one of the areas they're trying to grow is training more mental health professionals, right? The people, but also training the people in technology. The average age of a mental health clinician is 44, so they're considered digital immigrants in some definitions.
Oh, that's brutal.
And so they weren't people who grew up with technology, and so they're going to be late adopters too. So you have kind of an aging mental health profession who are not kind of early adopters of technology as well. Even myself, I consider myself I love technology, and I have SciPac, so I can do telehealth across state lines, and I don't. And why, I almost come back to my training didn't involve digital mental health. And I graduated 10 years ago from grad school. And so now I think training programs are also trying to integrate digital mental health. How do we as providers give evidence-based treatment across state lines, right? Consent process, outcomes measurement when the person may be in a different state. All these things are things we have to figure out, but that's not part of, I think, general training curriculum at this time. And so these are all sort of barriers, I think, too. But I think a big thing is the training, improving training, including technology in the training of mental health, the people.
And I think employers need to include that training as well, because we have clinicians who've graduated years ago and it wasn't in their initial graduate school training. And so something that we do at Cohen Veterans Network is we grow our own. And so we actively recruit. We have clinicians who are skilled and have been clinicians for many, many years, but then we also actively recruit individuals fresh out of graduate school who are still working on their hours towards a licensure, and we provide those hours. But we have a robust training program in which we focus on how to utilize telehealth, how to do group therapy via telehealth. And we do a lot of didactic training, and we do it via telehealth, and in some cases we'll fly to one of our locations and provide some additional hands-on training. And we also do it experiential, so like role-playing, how you share your screen with your client during the telehealth session, how you keep the group members engaged. But it's a lot of people, a lot of clinicians are not comfortable with it, and so the healthcare organizations need to invest in that training as well, and I'm glad that that's something we've been able to invest in.
Let me add to your question. So I think that even if we did all of this stuff, we did all the telehealth, everyone got trained magically, digitally, everyone had and knew it perfectly, there's still more demand than supply.
Yeah.
So we got 40% of people at some time in their lifetime are going to have an anxiety disorder. I mean, the prevalence rates and if you go into primary care offices, if you've gone to that primary care office 3 times this year, there's, not for mental health, for something else, there's a 50% chance that you have mental illness, right? Because either you got a medical condition, and that's why you're going all the time, so stroke, cardiac vascular disease drive mental illness, or you have an undiagnosed mental behavioral health issue, and you keep going in for headaches and back pain. So there's not enough people, even if we train them, even if we do it. So there's examples where I think we've done better. So if you look at pediatrics, in pediatrics, the pediatrician said kids should wear bike helmets and wear seatbelts. Those interventions decreased childhood trauma dramatically. There are bicycle helmets and seatbelts of child psychiatry. We know what we can do in families and communities to decrease kids that are exposed to adverse events. We just haven't gone out and made that happen. Because another way of fixing this mismatch is decrease the demand. And if you grow up, and we know what kind of family you need to grow up in, we know what kind of education you need, we know what kind of reading you need, all of those things could decrease the burden of mental health, and so now we'd have another, plus all this other stuff, you'd get a better chance of matching it. Red lights are blinking. This was a blast, at least for me. I hope you folks had fun. I hope you had folks fun. And then I think there's a party from 5, right now? Right after this.
In the Onyx room.
In the Onyx room, we're gonna do a lot of all the non-good mental health stuff, right? So I think there'll be alcohol, it's gonna mess up our sleep, all kinds of things that we just learned we're gonna throw away. But we'd be happy to talk with all you folks, and we really appreciate you coming, and great gratitude to all of you folks, and thank you for participating.
Thank you.
Thank you.